My name is Molly Schreiner, and I will be presenting to you about neural tube defects. Throughout this presentation, please refer to the neural tube defects worksheet in order to work on the challenge activity and take notes on the presentation. The challenge activity is Ellie is a new student in your school. Ellie's IEP states that she has spina bifida with specific symptoms of neurogenic bladder, mild learning disability, and trouble performing some physical movements. Ellie is placed into a third grade regular ed phys ed class. When you first meet Ellie, she seems like a very normal and active 8-year-old. She is able to walk normally, perform all basic locomotor movements with little problem. However, Ellie has difficulty adding the movements into more advanced sequences when playing with others. What are some recommendations you may have as part of Ellie's IEP team, and how would you structure a class for Ellie? First, I want to do a quick overview of the neural tube defects. They're a malformation of the spinal cord, brain, and vertebrae. There are three main types: encephalocele, anencephaly, and spina bifida. Next, we'll talk about the prevalence of neural tube defects. I would like to note that these numbers do not include pregnancies that were terminated. For anencephaly, it's about 2 per every 10,000 births. For spina bifida, it's 3 per every 10,000 births. And females are more likely to have neural tube defects unless the neural tube defect is at sacral level. And then the numbers are equal for males and females. Some other indicators of neural tube defects include increased maternal age, lower socioeconomic status, and a decrease in neural tube defects over the years includes pregnancy screenings, terminated pregnancies due to the screening results, enriching foods with folic acid, supplementation of folic acid during pregnancy, and improved medical care. The origin of neural tube defects. Neural tube defects occur during the first 26 days after fertilization of the egg during neurulation. Neurulation is the first step in the proper formation of the central nervous system. Then the neural groove folds over to become the neural tube, eventually becoming the spinal cord and the vertebral arches. Neural tube defects result when the neural tube is not closed completely, and specific causes of neural tube defects remain uncertain, although it is believed that both environmental and genetic factors play a role in neural tube defects. Some conditions associated with neural tube defects include chromosomal disorders, especially trisomy 13 and 18, as well as some deletions and duplications. Maternal exposure to certain medications, including anti-epileptic drugs, acne medications, and maternal alcohol abuse, maternal exposure to hyperthermia, like using saunas or having a high fever during pregnancy, maternal diabetes, and maternal obesity. And some early intervention and prevention options include the use of folic acid at least 4 milligrams per day prior to pregnancy and during the first trimester of pregnancy, and just generally prenatal testing. The general method of testing includes the first step is the alpha-fetoprotein, or the AFP testing, in which is a chemical typically found in the fetal spinal fluid, brain, and spinal cord. And then the AFP leaks into the amniotic fluid if there's a spinal opening. So they test the amniotic fluid to see if AFP is present. Then the other option after that is if they find a problem with the AFP, they use an ultrasound to detect abnormalities in head, neck, and brain, which they usually ultrasound a baby during pregnancy. Then amniocentesis, it's used after an abnormality is detected during an ultrasound. The levels of AFP and ACH are measured, and an elevated AFP and ACH and abnormal ultrasound typically confirm neural tube defects. And then, if possible, they may have prenatal surgery if it's a possible candidate. Now I'd like to talk about prenatal surgery. Some of the positive outcomes of prenatal surgery include less severe outcomes, more likely to walk independently, and better motor functioning. And some negative outcomes of prenatal surgery include no intellectual differences found between a child that has prenatal surgery and a child that does not, possible premature delivery, pregnancy complications, and tethered spinal cord. Now I'd like to focus on encephalocele. It is the incorrect formation of the skull, causing part of the brain to protrude through the skull. It typically occurs in the occipital lobe and may occur in the frontal lobe. Other medical conditions that typically occur with encephalocele include intellectual disabilities, hydrocephalus, spastic legs, and seizures. And the best outcomes for children with encephalocele would be that they have no abnormalities of the brain, no physical abnormalities, and it is frontal rather than occipital lobe location. The head circumference is in typical range, and there is less brain tissue in the protruding sac. Next, let's talk about anencephaly. Anencephaly is a condition in which no neural development occurs above the brainstem. Most important parts of the brain never develop. Parts of the skull and brain that are developed are deformed. Approximately 1/2 of pregnancies in which a fetus develops anencephaly are naturally terminated, and those born with anencephaly rarely survive the first few days of life. If you look at a child with anencephaly, typically they have really nothing above the forehead, very little development of the head above the eyes. And spina bifida. Spina bifida is the most common neural tube defect in which the vertebral arches split, causing a protruding meningeal sac. This sac may or may not contain part of the spinal cord, and is not to be confused with occult spinal dysrhythm. OSD is a condition in which the infant is born with a visible abnormality on the lower back, such as a birthmark, hemangioma, tufts of hair, opening in the skin, or a benign tumor called lymphoma. OSD may increase the risk of getting an infection, especially meningitis, due to the fact that the spinal cord is exposed to an opening in the skin. The spinal cord could also be connected to surrounding tissue, causing a neurological damage of the child as the child matures. So some forms of spina bifida include spina bifida occulta, which is closed neural tube with a defect in the vertebrae, meningocele, an exposed membranous sac covering the spinal cord. Then there is meningomyelocele, which is often referred to as spina bifida. This is the form that we will discuss most throughout this presentation. I will refer to it as spina bifida. It is an exposed sac, including the deformed spinal cord, and it is the most severe form. Here is a little diagram of normal embryonic development and then spina bifida in part C, as you can tell. As you look at part A, you see the neural plate, how it goes into the neural fold, then to the neural groove, and then it is the neural tube is closed. And then you can see the normal spine at birth, where the spinal cord, spinal nerves come out, and then there's a complete vertebrae. With spina bifida, you see that it may protrude out. There may be a part of the vertebrae missing, incomplete vertebrae, or even just part of it being pushed out of the way, so that defect pushes out of the with the spinal cord in it and the spinal nerves in it. Let's focus on meningomyelocele, which is what I said we would be focusing most on during this presentation. Some symptoms associated with it include complete or partial paralysis, sensory loss below the lesion, Chiari type 2 malformations, which is a hindbrain herniation with hydrocephalus. And hindbrain herniation just is fancy for a downward displacement of the back part of the brain. Neurogenic bowel or bladder, abnormal migration of the neurons, possibly causing learning disabilities. and it is considered the most complete congenital malformation. Typically, meningomyelocele are open at birth, and a portion of the spinal cord is visible. Treatment options for meningomyelocele. The very first priority is preventing spinal cord infection and protecting the exposed spinal nerves and structures. So during the first few days of birth or prenatal surgery, they use surgical closure, and it is typically followed by ventricular shunting procedure to prevent cerebrospinal fluid from leaking. Neurological impairments associated with spina bifida. Meningomyelocele affects the entire central nervous system. Some brain and spinal cord abnormalities include dysplasia of the cerebral cortex, displaced nerve cells, small gyri with abnormal layers or ridges in the cerebral cortex, abnormalities of layers, profound primitive development, small gyri with normal layers, malformations of the brainstem and the cerebellum, disorders of the cranial nerve nuclei, abnormal corpus callosum, which is the part of the brain that connects the two hemispheres, excessive fluid or splitting of the spinal cord, and scattered changes in the brain's cortex. And the primary abnormalities include paralysis, loss of sensation, learning disabilities, and the Chiari type 2 malformation, which is associated with hydrocephalus. Some symptoms of this include the difficulty swallowing, choking, hoarseness, breath holding, sleep apnea, disordered breathing during sleep, stiffness in arms, opsotonus, and vocal cord paralysis. I want to kind of look back at the sleep apnea part. Some may complain of this during awake and sleep periods, and children just may generally complain of extreme tiredness. And there are lots of different treatment options, but typically it's best to do a sleep study. And they may do an adenoidectomy or a tonsillectomy in order to remove the obstruction from the airway. There's also the Chiari type 2 decompression surgery, CPAP or BiPAP, which is the continuous positive airway ventilation during sleep to assist in breathing during sleep, and if necessary, a tracheostomy with mechanical ventilation. And the opsotonos, arching of the head backwards, is what it means. This can be treated by surgery to relieve the compression and allow additional space for the brainstem. During the presentation, you have heard about hydrocephalus. Hydrocephalus occurs in about 60 to 95% of children with meningomyelocele. It is most common in thoracolumbar lesions. It develops as a result of abnormal cerebral spinal fluid flow patterns and leads to enlargement of the ventricular system. It is diagnosed by neuroimaging studies, treated by implantation of a shunt. The shunt is used as a way to drain the fluid in the brain to another place in the body, such as the abdomen or pleural space, which is less common. And the shunts can become blocked and need to be monitored. And the symptoms of the blocked shunts include excessive head growth in an infant or a soft spot on the forehead. And for children, it's lethargy, headache, vomiting, irritability, and possibly paralysis and even visual paralysis, such as strabismus, double vision, or an upward gaze. As I said on the last slide, shunts can be infected or blocked or even fail. A shunt infection is similar symptoms to a shunt blockage. It could include fever, elevated white blood cell counts, and is treated with intravenous antibiotics. Partial shunt failure, you may see a change in personality, a decline in school performance, and weakness in the arms and or legs. There's also a new procedure out called endoscopic third ventriculostomy. It is a new treatment in which a hole is placed in the floor of the ventricles in order to drain the cerebrospinal fluid within the brain, although the effectiveness is still uncertain in relation to hydrocephalus associated with a neural tube defect. And just generally, early recognition of a shunt blockage, infection, and or failure is critical. Next, we'll watch a short video just kind of detailing some things about hydrocephalus.
Hydrocephalus puts pressure on the brain, which can cause long-term consequences like cognitive delays, mental retardation, even things like swallowing difficulties, to something as severe as coma. If hydrocephalus is treated in a timely fashion, then the kids with hydrocephalus can a lot of times go on to live very normal lives. They can go on to finish school, go on to secondary school, and they can also play any sport they want to, of course with parent supervision and approval.
Some other medical complications with spina bifida include some associated disabilities and medical complications. The associated disabilities include mobility impairment, cognitive impairments, seizure disorders, fine motor impairments, and visual impairments. And the medical complications include musculoskeletal abnormalities, spinal curvatures or humps, urinary and bowel dysfunction, skin sores, disordered breathing, atypical weight and stature, sexual issues, and allergy to latex. We're going to look at each of those categories on the last slide. Mobility impairments is dependent on the level of impairment. The higher the level, the more muscle weakness a child will have. For infants, you may see delayed rolling, sitting, and walking skills. In children ages 2 to 3, they typically learn to walk with the aid of bracing or no bracing. They can stand up and walk for short distances with support of hips, knees, and ankles. Types of bracing include parapodium, an adjustable standing brace, RGO, reciprocal gait orthosis, or HKAFO, hip, knee, ankle, foot orthosis, which is used with either a walker or crutches. And in children with low lumbar level lesions, walk with short leg braces and forearm crutches. And children with high lumbar thoracic lesions stand upright and walk for short distances, as I said, with support of hips, knees, and ankles. And during early adolescence, many start to use a wheelchair. The use of the wheelchair is due to the center of gravity and changes in strength. And it offers the child the advantage of speed, efficiency, and general appearance. Intellectual impairments. About 75% of children with spina bifida have typical IQ scores. They may have impaired perceptual skills, organizational skills, attention span, speed of motor response, memory, pragmatic language, and hand function. And about 25% have mild intellectual disabilities. Many children with meningomyelocele have ADHD that is unable to be treated with medication. And children with spina bifida and hydrocephalus typically have worse memory retention and functioning than a child with spina bifida and no hydrocephalus. A child with spina bifida and severe intellectual disability, they typically sustained from a brain injury as a result of prenatal hydrocephalus or a complication with an infected shunt. And the child with spina bifida and hydrocephalus, like I said, they usually are diagnosed with nonverbal learning disabilities, have better reading than math skills, and have difficulty with executive functioning. And seizure disorders. They affect about 15% of people with spina bifida. They are typically tonic-clonic, which is considered a grand mal seizure. They are the type of seizures that involve a loss of consciousness and severe muscle contractions. They respond to anti-epileptic medication. And a blocked shunt or a shunt infection is a possible cause for a new seizure development. Visual impairment. Strabismus is typically present in about 20% of people with spina bifida. They may require surgical correction. It can result from either abnormal visual gaze center in the brain or increased cerebrospinal fluid causing pressure in the brain. And children with visual impairment should see an ophthalmologist. Musculoskeletal abnormalities could include paralysis, muscle imbalances, and lack of mobility, which can lead to joint deformities. Some deformities may include clubfoot, which could require correcting with casting or surgery. Hip deformities, possible surgery if the child has potential to walk. Greater possibility of fractures, which they need to intake higher or adequate amounts of vitamin D and calcium, and the encouragement to perform weight-bearing exercises, as well as the development of arthritis due to abnormal gait and sensation. Spinal curvatures and humps. Approximately 90% of children with spina bifida have spinal curvatures or humps. Deformities include scoliosis, which is spinal curvature. It is treated with a molded plastic orthotic jacket and or surgery. Kyphosis, which is a spinal hump, which is typically treated by removing the hump. And kyphoscoliosis, which is a combination of a curve and a hump. They can develop before birth or later in life, and if untreated, can lead to problems sitting, walking, and breathing. In this diagram, you can see thoracic kyphosis, which is on the very top, and then lumbar lordosis, which it actually curves in the back, and then the scoliosis, you can see the curvature of the spine from side to side. Urinary dysfunction due to control of bladder by the spinal cord nerves. There's a high incidence of deformation of the kidneys. The bladder has difficulty storing urine and difficulty emptying the urine, which could lead to the risk of urinary tract infections and possible kidney damage. Some treatment options include CIC, which is the use of a catheter inserted into the urethra in order to empty the bladder, which is done about 4 times a day. Vesicostomy, typically used in infants. It's an opening in the abdominal wall from the bladder. It is created allowing urine to flow into the diaper. Medication, bladder augmentation procedure, appendicovesicostomy, volitional voiding, and Botox. Bowel dysfunction is due to control of the bowel by the spinal cord nerves. Lack of sensation of the anal function causes a person not to know when it is gas, liquid, or solid stool. Treatment methods for a young person may include time potty training, use of a daily laxative, fiber supplement, rectal suppository, surgical procedure including the Malone procedure, sacostomy, and the ACE procedure, and then biofeedback training. Skin sores. Many people with spina bifida have no sensation on their weight-bearing surfaces, such as their hands, feet, or their bottom. And if not detected, it may require hospitalization to remove the dead skin, plastic surgery if it has deformed the body, or intravenous antibiotics. The best way to prevent it is by examining the skin daily, replacing tight-fitting shoes or braces, avoiding hot baths, protective foot coverings when swimming, checking crawling surfaces, and checking wheelchair for fit. And weight and stature abnormalities. Increased risk of obesity. Approximately 2/3 of people with spina bifida are overweight. Prevention of weight gain by increasing physical activity, aerobic conditioning, strength training, and dietary restrictions, just decreasing fats and sugars. And then short stature treatment, where they actually give the person growth hormones in order to promote being a more normal adult height. Some sexual issues the person may encounter. For males, it could be lack of control of erections, use of medication and erectile devices in order to promote normal sex, possible problems with retrograde ejaculation. People with spina bifida are typically able to father children using in vitro fertilization or artificial insemination, and use of non-latex condoms due to the increased risk of latex allergy. And for females, they typically go through puberty early, about 2 years or more before others. They have normal fertility, should be monitored closely during gestation. They should use normal contraceptive methods They should decrease they have a decreased genital sensation, and they should examine for genital sores during sexual activity. I would like to note that there is an increased rate of sexual abuse in females with spina bifida. And allergy to latex. Approximately 50% of people with spina bifida have an allergy to latex, most common in children with multiple surgical procedures, and increases with age. It can be life-threatening and should be diagnosed through skin testing, immunocyte blood testing, and just avoid use of latex, including gloves, catheters, toys, balloons, rubber balls, band-aids, and ACE wraps. Some educational implications include during 0 to 6 months, there should be a referral to an early intervention program. 0 to 12 months, a sensory motor assessment. 4 to 5 years, a psychoeducational testing in order to determine strengths, areas of need, and realistic expectations, which is then used to develop the IEP. And during school age, it should be a regular review of the IEP and appointment with school physical therapist. Some social implications. Teenagers with spina bifida tend to show signs of immaturity. They may be socially passive, socially isolated, have lower self-esteem, have difficulty dealing with sexual changes, and difficulty dealing with feelings. Young adults with spina bifida tend to show similar signs, being socially isolated, the realization of the permanence of the disability, and sexual dysfunction. Positive outcomes associated with spina bifida include living independently, attending college, being employed, and establishing social relationships. Now let's review our challenge activity. We talked about Ellie earlier in our presentation, determining what your recommendations might be as part of Ellie's IEP team and how you might structure a class for Ellie. So I want you to take this time to pause the video and write down some of your answers to this. Now let's review our challenge activity. Some recommendations that I had. I would suggest thorough testing with a physical therapist to determine specific areas of need and additional findings for the IEP. Thorough testing with a school psychologist, addition of findings to the IEP as well. Adaptation of skills and equipment based on testing, IEP, and observation throughout the class period. Since she has an neurogenic bladder, I would plan with the nurse in order to develop a plan for bladder voiding prior to class. I know some students have bladder control problems and urges when completing physical activities, and just keeping an open line of communication with the parent and the student in order to determine when a problem is occurring or develop a more difficult skill when the student is having success. And here are my references. I hope this presentation taught you a lot about neural tube defects, especially spina bifida.